Now let me take this opportunity to invite our next speaker, Dr. K Mukherjee. He will be owing us with the varicose vein and venous leg ulcer management in Kolkata.
And a very warm welcome to the doyens of venous surgery in our country, Dr. Roy Varghese, Dr. Deki Wadia, Dr. Rahul Jindal, and Dr. Singh. I've been asked to share with you a kind of evolution of the current standards of venous surgery for venous insufficiency and venous ulcers in Kolkata. Now, both me and my main teammate, Dr. Jayanta Das, we started off in 2004 to do vascular, but we are from a general surgery background. And to be honest, we used to do a fair amount of general surgery, particularly breast, endocrine, and head and neck surgery. And then in 2009, we started doing endovenous work. I think we were the first in Eastern India and in this state to start endovenous ablations. And now we have a 3-member team and we do the entire gamut of vascular and endovascular surgery. Right, now what I'll do is I'll quickly take you through some of our own patients. I mean, pictures tell 1,000 stories. But it's very important to remember that there's a distinct, though there's an overlap, there's a distinct difference between primary varicose veins, which it may or may not be with an ulcer, and chronic venous insufficiency with or without ulcers. Now I can share with you just one fundamental sentence of my experience with chronic venous insufficiency for nearly 20 years now, and also substantial period of spent in the UK. Chronic venous insufficiency, like chronic pancreatitis, they are fundamentally hopeless diseases. We cannot cure them. So our whole idea is to try our level best to give the patient as good a quality of life as possible. So this is very important because the first time we consult a patient, we should be very truthful about making their expectations realistic. We do not use the VCSS system. We still use the CAP system, which Dr. Rahul Jindal just told you about. I'll just take you through a few photographs. These C1 spider veins and telangiectasias, generally we don't treat. We do not know the CLACS technology, but if we have to treat, we treat them with polytoconol with 26 gauge needle. Kind of mulberry veins, these are sometimes notorious to bleed. Typical primary varicose veins, we do not treat unless they are symptomatic. Yes, this will need treatment. This will need treatment. There are skin changes and dry ulceration. Quite neglected, and we often, at least in Calcutta, we see these patients have spent months, sometimes years, visiting different clinicians and having had all kinds of antibiotics. Just one more message I want to share with all the junior delegates. Antibiotics have very little role in the management of venous ulcers. Please don't start off with A to Z of antibiotics. Completely different ball game. This is the chronic venous insufficiency. As I said, there's an overlap between the two, but this is a distinctly different disease. This lady, again, there are no varicose veins, and you can see what is called the classical inverted champagne bottle appearance. And you can also see that she has got venous ulcers. Now, investigations, as it has been pointed out by Dr. Jayanta Das and by Dr. Jindal, the most important is the duplex imaging. We do use hand Doppler assessment in our clinic in some cases, but duplex is the most important imaging. There are occasions where you need an ulcer biopsy, and I'll show you some of our cases. We rarely do MR venogram. We used to do more MR venogram before, but we have now understood that IVAS is better than MR venogram. And now our team with Dr. Shubhabrata Banerjee, we are doing IVAS at a very low threshold. Right? Dr. Jindal told you the entire spectrum of modern management of varicose veins. We have used radiofrequency, we have used glue, but mostly we use laser. And this is the man we go back to. I mean, ultimately, the discovery of laser can be traced back to Sir Albert Einstein. A very classical photograph. This is 24 hours after EVL, and this is about 3 weeks after endovenous laser. And we often combine them with foam sclerotherapy. Now, if there are skin changes with or without ulcer, skin changes alone, there's nothing much we can do about it surgically. But whenever there is ulcers, we need to ask ourselves the most important question: with varicose vein or without varicose veins. Ulcers without varicose veins are more difficult to treat. And also we need to be sure, is it a venous ulcer? We need clinical examination and ultrasound Doppler, and occasionally an histopathology. You can see this ulcer, and it is not unusual to have atypical venous ulcers in this site. But if you look at the level of marbling, this patient had significant autonomic neuropathy. He was a diabetic, and this was an ischemic ulcer. Please, for the junior delegates, please do not forget to palpate the pedal pulses whenever you're assessing a patient with peripheral venous disease. This is the only patient thus far in our practice where we were unable to diagnose a pyoderma gangrenosum before a biopsy. You do not see any background changes of venous disease, and you see the exposed tendons of tibialis anterior. Similarly, you do not see any background changes of venous disease, a very punched out solitary local ulcer. This is very classical of vasculitis. So every leg ulcer is not a venous ulcer. That is again a take-home message, but most leg ulcers are venous ulcers. This was an erythema nodosum, quite classical if you remember your general medicine training days. Right, so when we are dealing with venous ulcers, the first thing is it's very important to exclude deep venous reflux. Because deep venous reflux cannot be treated with any of the treatment methods we are talking about right now. Now, in duplex, we look at main anatomical junction reflux, we look at other anatomical perforators reflux, we look at secondary perforators, and we look at subulcer bed perforators. And as we grew with this science, we realized that there are a lot of variations in the anatomy of leg veins. We recognize PA-GSV, AA-GSV, and Giacomini perforators, and they are present in about 30 to 40% of patients. Now, the principles of treatment is, if necessary, there's some kind of local wound care. There is no convincing evidence of benefit of one dressing method over other. So, we will leave it to you. But please be sure of what you're dealing with, that it is a venous ulcer, whether there is deep venous reflux, etc. Going by evidence, bed rest has a very high level of evidence. Treating varicose veins has a very high level of evidence. Layered compression dressing has a reasonably good level of evidence. Pentoxifylline also has a reasonable good of evidence. TERS, terminal interruption of reflux source, either with laser or with foam sclerotherapy. You can use 400 or 600 micron laser fibers through a 22 gauge Venflon or a Gelco. And of course, very important is long-term follow-up and compression. Compression alone will not be able to treat, but without compression, there is no long-term treatment. That's again my take-home message. These are the initial sites where, this is a classical area of venous ulcer, and this is the classical site of terminal interruption of reflux source. This is this is the ulcer, and you are studying the ulcer on table with a duplex probe, and you can see the perforators. Now, how do you know that this is the acoustic shadow of the medial malleolus? How do you know which perforators are the culprits? The general rule of thumb is any perforator more than 3 millimeters in size, just knock them off. At a time, I'm talking of 10, 12 years ago, we had a far lower threshold of doing a skin graft. And to be honest, we were quite happy doing them. Like in this particular patient, This would be, you're going to visible varicose veins, significant skin changes, C4A and C4B, and there is a combination of C5 and a large C6, a wet weeping ulcer. In these patients, we had a much lower threshold of skin graft. You can see a result very soon, and you can see the same patient about 3 months later, and we have a pretty decent result of a skin graft. Now, we have our own data, like the topic was what's happening in Kolkata. As I said, we started this group of treatments in 2009, and it's another patient. This was our kind of Rig Veda. At that time, VAI was there, but we were not very active members of VAI. Thanks to Dr. Das and a little bit of maybe 1% thanks to myself, we got to know the other doyens. 4 of them are sitting here today, and we are now quite active members of the Venous Association of India. But if you're really interested in pursuing a career in vascular surgery and venous surgery, this is a wonderful book, Jose Almeida's Atlas of Endovascular Venous Surgery. Right, we initiated a comprehensive ulcer care plan. I think I just have about 2.5 minutes. The phase 1 is general decontamination, moderate bed rest, and we start them on pentoxifylline. We also start them on flavonoids. We start them on Daflon. Phase 2 is we do use layer compression dressing, but initially we used to start with complete bed rest. Now we do not advise complete bed rest. And then phase 3 is we do EVL and TERS, and if required, ulcer debridement and skin graft. They are generally not required. Phase 4 is layer compression, continuous till healing, and then compression stockings allow ambulation. But phase 6 is very, very important, long-term follow-up. I'll spend 20 seconds, confessing this, sharing this pain with you. We have no problems with our patients from Kuch Bihar, from Jharkhand, from the Northeast, from Bangladesh. We have no problems with them. We have problems with patients from Bhawanipur, from Salt Lake, from Bagbajar, within the city. They don't come back to us. They come back to us 1.5 years, 2 years later, once they are again having a problem. And they buy the stockings diligently, but after a week, the stockings are neatly kept in the shelves in the almirah. So you have to be very, very careful that you maintain a good follow-up. We have results between January 2011 to September 2014. I'm sorry we could not keep maintaining results. We narrowly missed the opportunity, the wonderful opportunity which was initiated by Dr. Roy Varghese, Dr. Deki Wadia, Dr. Rahul Jindal. In 2017, there was a national study, and it was published in ASI Journal, guidelines about the data and guidelines about venous ulcers. Unfortunately, we were going through some troubled times at that time, but this is our data. We did total 159 cases, and our median follow-up was 18 months. A very basic aspect of medical statistics, median means only 50% of patients were followed up for 18 months. We had a very low primary failure, but our ulcer recurrence rate was pretty high. It was about 17% in about a median follow-up of 18 months. Now, I don't think that sort of compares very unfavorably with other major centers. One take-home message is that there is a learning curve. We were not that good at that time. But the second take-home message is, as I said, chronic venous insufficiency is a hopeless disease. And it is impossible to achieve a long-term ulcer healing rate of more than 90%. This is the ulcer recurrence. In our opinion, the main contributing factors to recurrence are accuracy of the terminal interruption, judgment of time and extent of debridement, and if at all you're doing a skin graft, the quality of the bed of the graft and compliance with stockings. Summary, we still do not know how venous ulcers develop. Most likely it is the white cell trap hypothesis, the Thrombosis Research Institute in London, which was headed by an Indian for a long time. Post-phlebitic ulcers with deep venous reflux are very difficult to treat. These are the patients who need careful evaluation with IVUS. Many of them need ileal stents. And that is something for the last 2 years we have been started doing with Dr. Banerjee and Dr. Das. Ulcers with primary varicose veins responds very well to EVL and foam sclerotherapy. And in our experience, medial ulcers generally tend to heal better than lateral ulcers. Ulcers without obvious varicosity need very careful evaluation and ultrasound Doppler. Ablation of subulcer bed perforators localized by on-table duplex is crucial to success. Primary skin grafting may be rarely required. To conclude again, leg ulcers may have protein etiologies. Accurate diagnosis of the etiology is the most important step in the treatment. Most cases, but not all, are venous ulcers. And a dedicated leg ulcer clinic with a full backup of a vascular surgical service is the best way ahead. And that is precisely what we have started in the AMRI hospital. It is just, well, aircrafts take off from the runway. They have a speed called V1, decision speed, and V2 when they rotate. We are still in V1, and we have been running in V1 for the last 3 months. Hopefully someday we will rotate and take off. Thank you very much. I think I was reasonably within time. Thank you.